evening, everyone, and welcome to the first Acome and LAUGHH Foundation Academic Updates. My name is Adriana Borges. I am a general practitioner from Colombia. I have been part of LAUGHH Medical Mission for 4 years. I am an alumni member of Acome, and I will be joining you as your host tonight. To begin, I want to mention our patrons that are making this incredible event possible. Go Asesores, the American Medical Student Association Intermetro Puerto Rico, Congreso de Expedientes Médicos, Students Network Organization, El Xavier, Editorial Médica Panamericana, Kaplan Medical, Cardio EKG, Grupo CTO, Felsocem, and Johns Hopkins University. Thank you so much for your supporting of globalization of medicine in Colombia, Latin America, and around the world. We would like to remind you the steps to obtain certification. You must be registered. At the end of every day, our team will enable the attendance form that is going to be open for an hour. It includes a keyword that will be displayed on the screen during the conferences. Finally, you must have attended at least 7 out of 9 days of conferences to get your certificate. And that's it. Remember that this is the 4th day of conferences. So this week we have been discussing children and women health. On Tuesday, we had 2 amazing conferences about cough and diarrhea in pediatric population and stress incontinence. Today, please welcome Dr. Jan Singer with his conference titled Breast Pain. Dr. Singer is a general surgeon with remarkable trajectory in societies like the American College of Surgeons, the Baltimore Academy of Surgery, the American Society of Parenteral and Enteral Nutrition, and also universities like the University of Maryland School of Medicine and Johns Hopkins University, among others. He obtained a Bachelor of Arts degree at the Cornell University. He earned a medical degree from the State University of New York, Downstate Medical Center, and a surgical resident program at Tufts New England Medical Center and the University of Maryland Hospital. Currently, Dr. Singer is the chairman of the board, Partners of Cancer Care and Prevention, and he makes part of the St. Agnes Hospital Foundation board. Welcome, Dr. Singer. It is such an honor having you here tonight.
Thank you very much for that introduction. As mentioned, I'm retired now, general surgeon, and one of the areas that I specialized in was breast surgery. And I consider it a privilege and an honor to be asked to speak to all of you this evening. I have been on multiple medical trips to Colombia, starting in 2006. And in March, it would have been my 23rd trip to Colombia. But unfortunately, because of the virus, it was canceled. I've been asked this evening to talk about breast pain, and I'm happy to do that. Okay, next slide. All right, let's review a little bit of the anatomy. The picture on the left and the left side of that, the pink area is the lung. This is obviously a cross section, is the lung. In front of that are cross sections of multiple ribs. And on the very top, you can see half of the clavicle. And that's important because you can see that the breast actually goes up to that level. On one of my trips to Colombia, a patient came over to me with about a 2-centimeter mass just below the clavicle. And she said to me that she went to her own doctor, who told her not to worry because the breast tissue doesn't go up that far. And that is not correct. You can see the breast tissue does go up to the level of the clavicle. And just in front of, just below the clavicle, you can see the pectoralis major muscle. And then in front of that is the breast. The yellow is fat. And then you can see the 10 to 12 ducts that drain into the nipple. And behind that are all of the breast lobules. On the right side of that same picture, you can see some fibrocystic changes with multiple large cysts in the lobular area of the breast. Next slide, please. So in terms of evaluating someone with a breast issue, number one, as with anything in medicine, is a complete breast history and physical exam. And this is very important, even if the patient has no symptoms. On my trips to Colombia, I've seen multiple women in their 70s and 80s, and the breast exam that I do is the first one they've ever had in their lives. And that's unacceptable. Even if a woman comes for a routine annual visit and she has no breast symptoms, a breast exam should be done. So the history and physical, most important for all patients. And then depending on findings, patient's age, etc., you might go to a mammogram, an ultrasound, an MRI, or a biopsy. And each of those are complementary. They show things that the others don't. So it's important that if one study doesn't show something, that you may need to go to another one. For instance, a mammogram will show a mass, but it does not tell you whether the mass is solid or cystic. The ultrasound is needed for that. The mammogram can show microcalcifications that are not seen on an ultrasound. And an MRI can show you masses that are not seen either on mammography or ultrasound. Next slide, please. In terms of presenting symptoms, as I mentioned just a minute ago, a lot of patients with significant breast problems, including breast cancer, have no symptoms at all. Pain is probably the most common symptom that patients present with when they do have breast symptoms. They also may present with a mass, skin changes, which could be redness or what we call peau d'orange, little dots on the breast, like the skin of an orange. The patient may have nipple discharge. The only nipple discharge, which is not really that important to work up, is a white, milky nipple discharge. Those are almost always benign. But if the discharge is bloody, clear, brown, those need to be taken more seriously. Patient may complain of thickening of the skin or change in size of the breast. Now, some women have, when they reach menarche at a young age, some of them develop a breast that is larger than the other one. So if a woman presents with different sized breasts, it's important to know whether this is a new finding, which could be very significant, or whether it's a finding that's been around for years and years. Also, scaly or itchy nipple may represent Paget's disease, which again is another kind of skin cancer. Next slide, please. So today's talk is mostly about pain in the breast, and this can be due to hormonal changes with the woman's cycle. It can be due to fibrocystic changes, and we'll talk a little bit more in a few minutes about fibrocystic changes in the breast. A fibroadenoma, a cyst, an abscess, or cancer. And this slide is ordered so that the most common symptoms are up on top. You can see cancer is on the bottom, and it usually does not present with breast pain. Next slide. There are also some non-breast causes of a patient complaining of, quote, breast pain. Patients with some heart disease, lung disease, even esophageal disease can think that they have a breast problem and have pain in the breast area. Certainly muscular, you saw the picture of the pectoralis major right underneath the breast, and that can cause pain that the patient thinks is originating in the breast. And also fairly frequently costochondritis, an inflammation of the joint where the ribs meet the cartilage, can cause pain very similar to breast pain. So you need to think about some non-breast causes when a patient comes in complaining of breast pain. Next slide. There are also some medications that can cause breast pain. Digitalis, methyldopa, spironolactone, and some diuretics. So therefore, it's very important when a patient presents with breast pain, as I mentioned early on, to do a complete history. What medications is the patient taking? This may be the cause of the patient's symptoms. Next slide. A very important question when the patient presents with breast pain is the pain cyclical versus non-cyclical? Does it occur mostly around her periods on a fairly scheduled monthly cycle, or does it occur anytime? The other significant question to ask is the pain unilateral or is it bilateral? A patient who presents with bilateral breast pain that's cyclical and occurs usually beginning just before her period and then ending a few days after her period, that's almost always fibrocystic changes or hormonal related and is much less significant than if pain is either unilateral or unassociated with the patient's cycle. The other thing to think about besides whether the pain is cyclical or unilateral or bilateral is an evaluation of the pain. So again, if it's cyclical and bilateral, you usually don't need very much of an evaluation of the patient if the physical exam is negative. But if it's unilateral in an older patient, you have to be much more concerned about something significant going on, and therefore you may need to go to, as shown in a previous slide, a mammogram, an ultrasound, MRI, etc. In terms of whether to start with a mammogram or an ultrasound, a lot of it depends on the patient's age. If the patient is usually below about 30 to 35, I almost always start with an ultrasound. Young women have more dense breast tissue, which is difficult to see anything significant on a mammogram. An ultrasound is a better test for the younger patient. Whereas someone who is over 35 or 40, I almost always start with a mammogram and then may go to an ultrasound after that. Next slide, thank you. In terms of the treatment of breast pain, you can see a list there of 6 things up on top. One is just changing, changing the patient's bra. Some women, especially with larger breasts, the breasts are pendulous, they hang down, and it's just the weight of the breast that causes pain. So a bra that's more supportive can decrease the pain. Also, some women wear bras that are much too tight for them. Or some bras have metal wires underneath to increase the support, and all of those things can cause breast pain. So sometimes doing nothing more than changing the bra can really help the symptoms. Since with hormonally related breast pain, there's usually swelling and edema of the breast around the period, decreasing sodium intake can decrease the swelling and therefore decrease the pain. Also, some people feel that decreasing caffeine intake also will not stimulate the estrogen and therefore decrease the pain. Topical pain relievers can be very important. They come in creams and gels, and they're the same kind that are used for pain in other parts of the body. Even an herbal thing like arnica cream gives the patient some relief. So topical pain relievers are important. Hot or cold compresses, and I usually tell the patient to try both of them because on some patients the heat works better, and on other patients the cold compresses seem to work better. It's important though to tell the patient if she's using the hot compress, don't make it too hot. You don't want to see her in the office next day with a burn on her breast because she overdid it. The other thing is mild pain medication, and I stress mild. I rarely, if ever, order anything stronger than acetaminophen or ibuprofen. You want to stay away from all codeine, morphine, opiates for chronic breast pain. They're almost never necessary, and of course, there's the possibility of addiction. So just mild uh, oral medication. Now, if the pain is cyclical, as I mentioned, that's usually due to hormones rather than other things. And oral contraception has been shown to kind of even out the level of estrogen, so you get rid of some of the peaks and valleys, and this can decrease the breast pain. Also, estrogen blockers like tamoxifen have been shown to decrease the estrogen level, therefore decrease the stimulation of the breast around the periods, and therefore decrease breast pain. So all these are treatments which you can do to help relieve the patient's pain. Next slide. Let me talk a little bit about fibrocystic breasts and fibrocystic changes in the breast, because as I mentioned earlier, this is one of the most common causes of breast pain. Number one, it's a benign condition. It occurs in over 50% of women sometime in their life. The usual age where it occurs the most is in the younger age groups between about 25 and 50. In other words, women that are menstruating. And histologically, fibrocystic changes are associated with cysts, fibrosis, and cellular hyperplasia. But it's important to know that if a patient has a biopsy or other findings that suggest fibrocystic disease, it's a benign condition. It is not a precursor for cancer. On one of my visits to Columbia during the question period, a doctor said to me that he's had patients with fibrocystic disease who later get breast cancer. So doesn't the fibrocystic disease cause the breast cancer? It was a good question. The answer is no, they're not related. But when 50% of women have fibrocystic changes in the breast, some of them later on are going to get breast cancer, but it's not a related condition. Next slide, please. Some of the symptoms of fibrocystic changes: lumpy breasts, the pain and tenderness that we've talked about. A patient may present with either green or dark brown nipple discharge. The breasts feel full, swollen, heavy, and the symptoms usually are worse just before menstruation begins, again because of the high hormone levels and the stimulation of the breast tissue with the estrogen. When you examine these patients, and when I teach the young doctors about doing breast exams, these are some of the most difficult exams because there's little fine nodules all over the breast. And until you get to examine a lot of breasts, it's hard to distinguish between what's a small little benign feeling nodule and what's a more significant one that needs further workup. And it's just a matter of experience. But fibrocystic breasts can be a challenge. They can be lumpy and tender all over, and it's hard to distinguish what's important and what is less important. Next slide, please. But let's talk a little bit about just masses in general. Either a patient who presents with a mass, or on examination, you feel a mass in an asymptomatic patient. Number one, fibrocystic changes, we just talked about. Fibroadenomas, which are also fairly common and are benign, solid lesions of the breast. An abscess can present with a mass, a simple or complex cyst, fat necrosis, where a portion of the breast fat loses its blood supply and becomes necrotic, And on mammogram, it can look very much like a cancer. A dilated duct may present as a mass, usually right around the nipple. Lobular carcinoma in situ, which is not really a cancer, but has an increased risk down the road of leading to cancer, can present with a mass. And obviously, cancer itself can present with a mass. So when you find a mass in a patient, there are lots of things that can cause it. And going back again to the taking the history and doing the physical and finding out about if there is pain and so forth and what it's like, that will help you determine what studies to do and what the masses may be caused by. Next slide. There are certain myths about breast lumps. I've heard patients say it hurts, so it can't be cancer. Or I've heard patients say it doesn't hurt, so it can't be serious. And other patients have said, my family history is negative, so I can't have cancer. All of these are untrue. It's true that most cancers do not present with pain, but it certainly can. The fact that a mass doesn't hurt certainly does not mean it's not serious and isn't. And the third item, newly diagnosed patients with breast cancer, 2 out of every 3 newly diagnosed patients have a negative family history. So that most women diagnosed with breast cancer have nobody else in their family who's had it, even though there are obviously genetic families and so forth. The majority have no other family history. Okay, that was quicker than I thought. Any questions?
Thank you so much, Dr. Singh, for your amazing presentation. I think that one thing that you said is really, really important is that Colombian woman has a lot of myths about breast, and we'll still think about our breast with like shy or with kind of like so timid about it. So it is amazing to just be able to talk like openly with our patients. So we're gonna
Yeah, go ahead.
We're gonna check for questions, and while our staff is doing that, I want to say on behalf of Acome and the LAUGHH Foundation, thank you to our participants. We have almost 1,500 people all over the world, from American countries, of course, but also people from Spain, Burundi, Ghana, Kazakhstan, Nepal, Nigeria, Egypt, Sudan. People that is making incredible effort with their local time. So going with the questions, the first question is it unusual finding to feel a little mass or breast changes during menstruation time?
No, this is very common. As I mentioned, fibrocystic changes, fibroadenomas, all can be stimulated by estrogens around menstruation, so that a mass found during menstruation may be gone 2 weeks later. So it's very common to feel some small masses during menstruation. But let me just go back also to what you said. On my trips to Colombia, it's amazing how many women are shy about being examined. I mean, they know they're coming to see me for a breast exam. That's what they've been told. And they take off their blouse and they sit there with their bra on. When I say to them, you really have to take your bra off also for me to examine you, they get very shy. So yes, that's part of the Colombian culture. Also, I've heard other myths, thinking about it, of women saying that deodorants and things like that cause breast cancer. And absolutely, that's not true.
Thank you, Dr. Singer. Is there any post-operative pain related to mastopexy or breast surgery?
Yes, as with any surgery, there is post-operative pain, whether a patient has mastopexy or a lumpectomy or mastectomy, any kind of incision, any kind of operation, breast augmentation, breast reduction, they all will have some pain post-operatively, yes.
And how we can treat it?
I'm sorry, say that again?
How we can treat it? Like give the treatment. What do you recommend?
Well, for post-operative pain, it depends. If a woman's had a small incision for a biopsy, she needs very little. If she's had a mastectomy and has a large incision, you have to give her much stronger medication for a week or two. So it really depends on the amount of surgery the patient's had and how big an incision, etc.
Okay, thank you. With the diagnosis of fibrocystic disease in our patient, how frequent do we have to use images to rule out cancer as a screening? And how frequent do we have to follow up the fibrocystic changes?
So if the patient's presenting with pain, as I mentioned, if it's cyclical, occurring around the menstrual periods, and it's bilateral in a young woman, if the physical exam doesn't show very much, I wouldn't get any studies. At most an ultrasound if you're not sure what's going on. But if the pain is only on one breast and it's not cyclical, then more studies. An ultrasound in a younger patient, mammogram in someone over 35 or 40. And then if a mammogram shows a mass, then you might want to go to the ultrasound to find out whether the mass is cystic or solid. The other part of the question was how often you have to see the patient. Again, if you're pretty sure it's fibrocystic changes, I would say once a year is fine just to follow up. I saw on one of my recent trips to Colombia a 23-year-old woman, relatively small breasts, an easy exam, complaining of bilateral breast pain around her periods. The exam was negative. It was clearly due to hormonal changes. I told her if she continued to have breast pain in another 30 years, she should come back and see me.
Okay. Good night. Thank you for this opportunity. With what frequency and from what age do you recommend for a woman to make a breast control in order to prevent?
I'm not sure I understand the question. To make a breast control in order to prevent, I need a better explanation of that.
I think Juan David is talking about cancer and what time do we need to start consulting to the general practitioner just to check our breast?
Well, I think that women ought to do breast self-examinations every month. I know the American Cancer Society does not recommend that, but I think, and I think the reason they say that is that if a woman does a breast exam and she doesn't feel anything, she say, well, I don't have to go to the doctor. I don't have to get a mammogram because I'm fine. You have to stress to the patient that just because she doesn't feel anything doesn't mean that there's nothing significant there. But I tell patients to do a breast self-exam every month, about 2 weeks after her period is over, if she's still menstruating, and do it in the shower when her hand and breast is wet and soapy, because it's much easier to feel something. So that's the breast self-exam. I know in Colombia, if I remember correctly, mammograms are recommended every 2 years, starting at age 50 to age 69. In the United States, we usually start a little bit earlier, but that's what's recommended in Colombia. But if you see a 40-year-old woman with a mass, you clearly have to get a mammogram and probably an ultrasound. I hope that answers the question.
Yeah, I think you do. A 24-year-old female keeps lactating a lot after 2 years of childbirth. She isn't breastfeeding anymore. Is it normal?
I've seen this before. I wouldn't call it normal, but if it's bilateral and so forth, I don't think it's anything serious. She may want to go to her obstetrician and get a prolactin level or other hormone levels to see if they're still elevated after the childbirth. But a white discharge, even 2 years after childbirth, yes, it's a little unusual, but it doesn't sound like anything very significant.
Thank you. Greetings from Venezuela. If we are in a rural environment, what would be the criteria for referring the patient to the hospital?
It varies. When you say rural environment, it depends on what you have available there. On my trips to Colombia, sometimes we were in a big city like Cali, and sometimes we were up in the mountains in little towns. And so it really depends on what's available. If you're in a small rural community and you feel a breast mass and you don't have a mammography machine in your town, the patient will probably need to be referred to a larger center where there is mammography available. In terms of just going, so it's getting the mammogram. It's not to a hospital necessarily. I don't know if there are non-hospital clinics there that have mammograms, but it's not a question of going to a hospital. You need to evaluate the patient the way we discussed earlier. And if you don't have those facilities available in your rural area, then the patient should be referred to a different kind of center, to a larger community where she can get those studies. Again, though, you can do a complete history and you can do a good breast exam regardless of where you're located.
Can a mammogram be wrong? If it can, how else can you make an accurate diagnosis?
That's a good question. Mammograms miss 10 to 15% of breast cancers, especially in younger women who have dense breasts. And that's why I talked about starting with an ultrasound in younger women. Let me tell you a little bit about a patient that I had probably 25 years ago now. A woman in her mid-40s came in saying she felt something in her breast. It just felt abnormal, like a thickening, whatever. I examined her. She had fairly small breasts that were easy to examine. I didn't feel anything. But because she was in her mid-40s, I ordered a mammogram. Mammogram was negative, perfectly normal. I ordered an ultrasound, which was normal. And I said, I don't feel anything and the studies are normal. If you still think you feel something there in 3 months, come on back. She came back in 3 months and said, I still feel this. My exam again was totally normal. I didn't repeat the mammogram because it was only 3 months before, but I repeated the ultrasound. It was again normal. But she insisted that she felt something. I said, okay, this is what we're going to do. I'm going to take you to the operating room. You're going to point to the exact spot where you feel something. I'm going to put a mark on it, make an incision, and take out the tissue from that area. I did that, and she had a 2-centimeter cancer. It was missed on physical, it was missed on mammogram, it was missed on ultrasound. So no test is 100% accurate. They all can miss things.
Wow. Thank you, Dr. Singer. That was the last question.
Okay.
We really appreciate you being here with us tonight, and we hope to see you soon in our medical mission.
I hope so. I hope things clear up with the virus and so that we can start going back there. I love coming to Colombia.
Thank you, Dr. Singer.
Thank you very much for inviting me to participate. I really appreciate that.
Thank you.
Okay. Bye-bye.
Marta es uno de los tuyos. Es estudiante del MIR. Se esfuerza en todo momento para superarse, como tú. Repasa sus marcas a cada paso, pero no estudia como tú. Porque Marta es pro-MIR. Ha encontrado un método, su método.
Buenos días, Marta. Hoy entrenaremos valvulopatías. Actualmente has alcanzado el 60% de la nota máxima en esta asignatura, un 10% superior al resto de los aspirantes. Si alcanzamos el 80%, podría suponer entre 5 y 7 puntos en el MIR y habrás superado tu nota objetivo.
Promir ha desarrollado el entrenamiento que se ajusta a Marta. Analiza sus fortalezas y debilidades, se adapta a sus objetivos, optimiza sus esfuerzos, muestra la evolución de sus resultados para que Marta tenga claro que alcanzará la plaza que quiere. Hemos volcado 60 años de experiencia en Promir y ahora es su centro de alto rendimiento. Por eso Marta es Promir. ¿Eres tú, Promir?
Santander, un paraíso abrazado por la majestuosidad del cañón del Chicamocha. Cuna de la libertad de América, corazón de Colombia y orgullo de miles de santanderianos soñadores y trabajadores que enaltecen la grandeza de nuestro departamento. Aquí, hace 6 años nació Acome Santander, una organización de estudiantes de medicina de la UIS UNAV y UDES que juntos trabajan por dejar huella y construir un país mejor.
En Acome Santander formamos líderes que luchen por un bien común.
En Acome Santander llegamos a todos los rincones de Colombia llevando un mensaje de esperanza y bienestar.
En Acome Santander nos caracteriza la alegría y el deseo de triunfar como equipo.
En Acome Santander nos representa la unión y el trabajo en equipo.
En Acome Santander promovemos la salud y el deporte.
En Acome Santander repartimos sonrisas y dejamos huella en la población.
En Acome Santander somos parte de la aventura de nuestro departamento.
En Acome Santander nos une el respeto, la empatía y las ganas de crecer juntos.
En Acome Santander nos conectamos con el medio ambiente para preservar la vida.
En Acome Santander somos una familia que permanece unida, sin importar el tiempo ni la distancia.
En Acome Santander luchamos por nuestros derechos y por un sistema de salud digno para todos los colombianos.
En Acome Santander innovamos y le abrimos un espacio a la academia y a la investigación.
En Acome Santander enseñamos y aprendemos juntos.
En Acome Santander levantamos la voz por aquellos que no tienen la oportunidad de hacerlo.
En Acome Santander somos médicos más allá de los consultorios.
Acome Santander, sé parte del cambio.
El turismo médico es cada vez más importante como renglón en la economía de nuestro país. Muchas ciudades están apostando a esto como otra de las economías naranjas y como esta industria sin chimeneas. Por eso es importante poder tener ese dominio sobre el idioma inglés para poder atender a todos los extranjeros que vengan a nuestro país y tengan una mejor interacción con ellos. El Colegio Médico Colombiano ha decidido hacer este convenio con Focus para poder obtener unas grandes ventajas en el aprendizaje de este idioma y así el médico pueda progresar en su comunicación con el mundo.
Mientras siga viendo tu cara en la cara de la luna, mientras siga escuchando tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti. Mientras siga viendo tu cara en la cara de la luna, mientras siga escuchando tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti, mientras siga viendo tu cara en la cara de la luna, mientras siga escuchando tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti. Mientras siga viendo tu cara en la cara de la luna, mientras siga escuchando tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti. Mientras siga viendo tu cara en la cara de la luna, mientras siga escuchando tu voz entre las olas, entre la espuma, mientras tenga que cambiar la radio de estación porque cada canción me hable de ti, de ti, de ti.
Acome Capítulo Santander se siente afortunado de contar con más de 400 miembros que con orgullo hacen parte de la gran familia de Corazón Azul. Nos brinda alegría hacer parte de la formación de médicos cuya labor va más allá de los consultorios. No es suficiente con ser buen médico, sino excelentes personas. Desde cada corazón henchido de orgullo en este capítulo, deseamos feliz cumpleaños a la Asociación Colombiana Médica Estudiantil.
We would like to remind you the steps to obtain the certification. You must be registered, and at the end of every day, our team will enable the attendance form that is going to be open for an hour. It includes a keyword that will be displayed on the screen during every conference. Finally, you must have attended at least 7 out of 9 days to get your certificate. And that's it. Remember that this is the 4th day of conferences. I'm so sorry. Now it is time to continue with the second conference named American Prenatal Care. Please welcome Dr. Taro Adachi. Dr. Taro Adachi is a member of the Fellow of the American Congress of Obstetricians and Gynecologists. He obtained a Bachelor of Arts at Johns Hopkins University, a medical degree from State University of New York, and an obstetrics and gynecology residency at the University of Maryland Medical System. Currently, Dr. Adachi works at the Life Bridge Health at Sinai Hospital in Baltimore as a full-time general obstetrician and gynecologist, and he is also part to the residency and medical school training faculty. Dr. Taro?
Hello.
Hello, Dr. Taro. How are you?
I'm sorry, the nighttime resolution creates a different brightness than I'm used to in the daytime, so I look like a ghost. But
don't worry.
I think we're ready to roll.
Welcome.
Thank you very much. A pleasure to be here. So I think you're controlling the slides tonight.
We're going to share the slides. Just give our staff a second.
Absolutely.
Just preparing it.
All right. So as was mentioned, we have a full OBGYN residency training program at my institution. So every day, all my clinical work is involved also with teaching as well as practicing. And we have medical students who come to us from Johns Hopkins University who are in medical school. So we have medical students on a regular basis completing their clinical rotation in OBGYN with us.
Dr. Taro, we had in our previous conference, we had a question that I think that it would be very good if you could give us your opinion. The question was, it is like a clinical case. It's a 24-year-old female keeps lactating a lot after 2 years of childbirth. She isn't breastfeeding anymore. Is it normal?
So yes, you want to separate what might be a ongoing lactation from pathological galactorrhea. So certainly, checking for sources for abnormal bleeding, whether it be medication side effects. Some of the psychotropic medications can cause galactorrhea. Certainly after breastfeeding, there can be ongoing stimulation. So with sexual stimulation of the nipples, increased temperature like in the shower, those can be times that you can get physiological expression of milky substances. And so it's also a question whether it's spontaneous or stimulated. So it certainly can be normal, but it's important still not to ignore other possible causes for galactorrhea.
Thank you, Dr. Taro. And also, I have a question, like how much time is like the mean time to stop lactating after having a child?
After the mother stops breastfeeding, how long will it continue? That does vary from person to person. If one were interested in actively suppressing milk production, generally we recommend sort of even binding of the breasts with like an ACE bandage or a sports bra, and using cooler temperatures, so like ice packs, for example, and that can facilitate the decrease in normal lactation once breastfeeding is completed.
Okay.
The time varies, though.
Thank you, Dr. Taro.
Certainly. Is that full screen for you, or are you coming still to full screen? Yep. All right. So this evening's topic is American prenatal care. And I smiled at first because to present prenatal care, which comes in whole books, can be a daunting task. So I've targeted really for upper level medical students who have some clinical experience. And I've tried to create a little structure almost as we go through, but I think you can't really discuss prenatal care without first talking about preparation for pregnancy. We can go to the next slide. So at least a good portion of the talk, we're going to talk about preconception care, and that probably pertains to most of you in medical school now because you are going into different specialties. Many of you will come across patients who, through primary care or even specialty care, you might be aware that their intention is to become pregnant. And so you have a responsibility to try to focus on their medical problems and try to optimize or make as good as possible their health prior to pregnancy occurring. Next slide. So again, the preconception preparation breaks down into three main areas. Again, trying to focus on existing health problems, which we'll discuss in some detail, looking at general nutritional considerations, and then counseling them about genetic risk factors and preparation, something that technologically you may or may not have some of the resources that I'll discuss today, but at least bringing up things that are historical, and again, we'll cover this. Next slide. So I'm in an inner city, pretty common to many busy cities in the United States and most busy cities around the world. While this is by no means a comprehensive review of the pre-existing health problems we can experience, I'm going to focus on these 5 in terms of preconception health, because they're quite common in our city and probably yours as well. We can go to the next slide. So diabetes is certainly a major health issue. In pregnancy, diabetes is associated with fetal deaths, both miscarriage in the first trimester as well as stillbirths anytime during the pregnancy, and certainly correlating to how well a diabetic can be controlled. Similarly, in the preconception preparation, somebody becoming pregnant with poor glucose control is at risk for creating birth defects, sometimes before they're even aware that they're pregnant. These defects can involve the heart, like a ventral septal defect commonly discussed, but also areas of the brain, the spine, the urinary tract, and the gastrointestinal systems. In pregnancy, diabetes is associated with larger than normal babies and can be associated with other complications of pregnancy, such as preeclampsia, a blood pressure-related complication. Next slide. So in our students, when we teach our students, we really try to focus on teaching them to do good medical histories. It's an extremely important tool, and this can't be overstated. So particularly when you're trying to sort out difficult medical problems, pre-pregnancy or otherwise, a good thorough history is quite important to let you direct what testing you might do, what assessments, and what plans need to be put into place. So for a diabetic, for example, it's important to know what type of diabetes they experience. Is it type 1 or type 2? Whether they've had complications in their life for diabetic ketoacidosis or hypoglycemic episodes, whether they've experienced infections that were difficult to treat. Diabetics who are poorly treated can develop, of course, organ system damages, and we think of retinopathy as well as kidney damage. And it's quite important to understand their medical regimen and how they support that in terms of their understanding, their financial resources to pay for medications, whether they need support in remembering to take them, and how they're followed. Next slide. So in the preconception preparation process for diabetes, you really need a multi-team approach. As gynecologists, we try to educate them about the perils of diabetes in pregnancy, the importance of trying to improve their diabetic control prior to even attempting conception. We provide contraception for those who are really in poor control to try to buy some time to control these things. And of course, again, focusing on their various supports, both medically and socially, to help them manage their diabetes now and hopefully for the future. The goals often are stated as trying to stay within a glycosylated hemoglobin level of 6. In some of our standards, we see them saying no more than less than 1% above the normal of 5.7. So as a simple blood test to determine where things are, that's a reflection of the average sugar control over the prior 90 days, and a pretty easy measure to follow. Next slide. If we look at high blood pressure, pregnancy risks of high blood pressure can include fetal growth restriction, low birth weight in general, prematurity, preeclampsia, and other complications such as premature separation of the placenta and abruption. Next slide. We can go to the next slide. So preconceptually, you want to also understand whether other organ systems have been I'm sorry, you can back up one. Understanding whether their other organ systems have been affected by hypertension, such as the kidneys, looking at their current medication choices and trying to be aware of getting them control on medications that they could potentially continue during pregnancy, as opposed to having to go through a change of medications when pregnancy occurs. Some medications like the ACE inhibitors and the angiotensin receptor blockers are considered teratogenic, and so to have a patient come off these types of medications before trying to conceive is important, because again, once pregnancy is diagnosed, some issues may have occurred. These agents in particular can affect fetal kidneys. Other choices, old medications like methyldopa, still actively used and safe in pregnancy. Both labetalol and nifedipine are used in pregnancy for a number of reasons, and certainly would be good choices to have patients controlled on prior to pregnancy occurring. In pregnancy, there is controversy as to whether we improve outcomes for patients who are in the mild to moderate elevations of blood pressure, but certainly in the non-pregnant patients, we should be really looking for a normotensive state as our goal on medications that we can continue. Next slide. So we have a kind of lumped together tobacco use and abuse, as well as other substance abuse. And in most major cities, unfortunately, around the world, we see a wide range of substances, from marijuana, cocaine, heroin, and so forth. So I am kind of lumping things together for the sake of time, but be aware that in pregnancy, substance uses can be related to nutritional deficiencies. We can experience cardiovascular complications for the mother. We can see fetal growth restriction to fetuses and complications of placental separation prematurely with agents like cocaine. Next slide. So preconceptually, of course, we're trying to identify the problems by a thorough history, try to assess the impact on them nutritionally, and get them involved in cessation counseling, as well as support to understand the sort of the family context of their disease, changing their environment if possible, and so forth. Education regarding pregnancy complications is certainly important. I think the awareness is present, but I think to emphasize specifically some of the complications is important as well. Next slide. Obesity is another problem that is rampant in the United States and in other parts of the world. In pregnancy, obesity is associated with miscarriage early on, gestational diabetes. It does have a separate association with preeclampsia. We can see a higher incidence of venous thromboembolisms, or DVTs, deep vein thrombosis, and again, other medical comorbidities, hypertension, pre-existing diabetes. So a significant problem. Next slide. So preconceptually, body mass index is a relatively simple measure to look at. Ideally, you'd like to be a body mass index of 25 or less, or in normal range. Above 25 does increase risk, and then as we go to BMIs above 40, we see higher risks of all the complications that were discussed. So, this is a difficult problem to tackle, whether pregnancy is planned or not. But of course, education, diet, and activity to reduce BMI pre-pregnancy is a straightforward goal, and probably a lifelong health goal as well. Next slide. Mental health also covers a wide range of problems for anxiety and depression. We also see various psychoses, schizophrenia, bipolar disease. So obviously you're going to want to get a good history and a good assessment of a patient who experiences any sort of mental health issue. In pregnancy, mental health issues are associated with inadequate nutrition, failure to follow up on medical medical care with their healthcare mental health providers, but also with their prenatal care. There can be alcohol or substance misuse as patients try to self-treat for mental health. There is a higher instance of domestic violence, and then associations to postpartum depression and suicide. Next slide. So mental health-wise, again, screening to get an accurate diagnosis, understanding the social context of the disease, their family situation, their resources to find support, and then, if possible, treatment and an adequate person or persons to follow up their mental health with both pre-pregnancy and during the pregnancy, so that co-management sometimes is quite beneficial. Next slide. So if we move on to the next category of nutritional considerations, next slide. There's some basic items recommended for anybody planning to conceive. Folic acid, while it can be found in many foods, is probably best taken as an actual supplement to make sure that the reliable level of folic acid is provided on a daily basis. It's a relatively inexpensive thing that most of our patients, even with low incomes, can find and afford. They don't really need to take a prenatal vitamin or even a multivitamin, but folic acid on its own. Now, for patients who have had, and I should back up and say that folic acid's primary goals are to reduce a limited number of birth defects that occur to women of all ages, and more so after age 35, specifically neural tube defects, things like spina bifida, for example. Important to know that if a patient has had a prior baby affected with a neural tube defect, then their preconception dose should be much higher, 4,000 micrograms, 4 milligrams in different units, as opposed to just 400 micrograms. In general, addressing any dietary limitations, any weight goals relates to controlling obesity, and then iron, calcium, and vitamin D are certainly things that are relevant to women's health in general. In pregnancy, we do see quite a bit of anemia, so making sure they have iron stores to help them create, the blood cells necessary during pregnancy, and to help avoid anemia, which is exacerbated often in pregnancy by dilution. Next slide. Excuse me. Lastly, in our preconceptual preparation, identifying genetic risks and counseling are important. Next slide. So for a patient who has not become pregnant yet and is otherwise normal, there is a potential to carry genetic mutations in their DNA, and that if paired with the right or wrong partner, as it were, a fetus can be at risk to develop that disease. This concept has evolved pretty quickly over the last few years here, and again, maybe a technical limitation depending on what part of the world you're in. In prior days, we tended to discuss cystic fibrosis, spinal muscular atrophy, and Fragile X more commonly in certain populations. In New York City and certain parts of Baltimore near our hospital, we see a large Ashkenazi Jewish population, so Tay-Sachs disease was pretty common. And other things like thalassemias affecting Asians and others, sickle cell disease, the Black population in America. So what we've had available to us now is referred to as universal genetic carrier screening. And it's an important distinction because as we've learned more about genetics and DNA, we're all more the same than we are alike. And if we only screen for diseases based on our perception of their culture or understanding of their culture, we miss a lot of these mutations. So universal genetic screening refers to a panel that screens for diseases that affect human beings. The panel that my practice is currently using actually looks at 176 diseases, and these aren't random. They're considered, quote, relevant diseases, and so things that can affect potentially baby in utero, can affect the baby as a newborn, or might have a dramatic impact on the development of a child into adulthood in their life. So not exactly a random list, but an ever-growing list still. Next slide. Oh, I'm sorry. Can you back up one? I'll come back to in a later slide, but PGD is pre-implantation diagnosis. So in the world of assisted reproductive technologies, the ability to screen for some of these diseases from a cell from an embryo is another technological option, and may screen for some of these same diseases. Otherwise, in the absence of pre-existing disease, fertility folks who are clearly working with patients who are attempting to become pregnant really should be offering this type of universal genetic screening prior to pregnancy for education purposes. And again, just to give you a sense of how simple the testing is, it can be done with a simple sample of basically spit, as long as the sampling is done at least an hour or more after eating or drinking or even chewing gum. Next slide. So in terms of general genetic risk assessment and counseling, We want to get a good family history to identify if there are any significant birth defects in the family or fetal abnormalities that occurred. That's going to focus our attention on offering different testing in the preconception time period. We also spend a lot of time discussing risks for patients who are going to be 35 or older at the time of delivery. Statistically, that's considered advanced maternal age in terms of risks for chromosomal defects and a baseline of abnormalities. As patients get older, they both experience decrease in fertility as well as an increase in chromosomal problems, aneuploidy, and pregnancy complications. And certainly as we look to more and more patients who are 40 and older in our practice, here we also see that almost any pregnancy complication occurs at a greater rate. So having this type of counseling preconception at least prepares a patient for what they're going to experience and what they should be aware of. Next slide. So before we can get to the delivery room, and this is one of our rooms, and much like real estate photographs, it's much larger than it actually is or appears larger than it is in reality. But our type of rooms here have a delivery bed that we can break down for deliveries. We have an area for the resuscitation of fetuses immediately adjacent, and a waiting area for families within the room who are going to share the birth process. But again, before we can get here, we need to initiate prenatal care. So we can go on to the next slide. So I'm going to try to set this up as kind of a flow through pregnancy with some distractions. That's kind of how my brain works also. So for an initial visit, we're usually seeing patients about 6 to 8 weeks from the first day of their last normal menstrual period. One of the most important aspects is to confirm that we have a viable pregnancy and to confirm the correct gestational age. As we'll talk about shortly, we often are comparing the estimation using their last period as well as the ultrasound. And this is quite important because some of the testing that's offered is occurring in a very specific time frame during pregnancy, and after that, you might miss the option. So getting the dates right counts. It also has an impact potentially at delivery time if there were needs for elective induction. Making sure that you have what we refer to as good dating is important, because you hate to induce somebody and find the baby might be premature, or delay delivery and find out that that baby was actually older than expected and has a higher incidence then of becoming larger or having sudden fetal death. Medical history and mental health screening, again, cannot be underemphasized or emphasized enough as important to identify things. And in obstetrics, we really are a paranoid bunch, really sort of expecting the worst, trying to identify things that might happen so that we can prepare ahead of time. And granted, many pregnancies can be low risk, and even in our community here, we have many patients who choose as little intervention as possible, and that is fine, and we like to go along with that. But it is still important to try to help identify where risks may occur for education, counseling, and offering correct assessments at the right times. Next slide. So again, with the importance of ultrasound, just to give you some idea, and sorry if this is a little bit hard to read, but we usually use early on what's called the crown rump length, measured from the tip of the head to the bottom. And if the pregnancy is in the range of less than 9 weeks, then the ultrasound really should be within 5 days. If the discrepancy, the difference between the age of the baby is more than 5 days from the last period, the ultrasound is considered more accurate. Between 9 weeks and just under 14 weeks, that discrepancy can be as far as 7 days before you would choose the sonogram over their last menstrual period dating. Beyond that time, we tend to use different measures: the biparietal diameter, the head circumference, the abdominal circumference, or the femur length. And with those measures, estimating age of the baby, you can see that the discrepancies are 7 to 10 days, and beyond 22 weeks, the discrepancies can be 14 days, so less optimal for being accurate. Next slide. So at an initial prenatal visit, we optimally are offering the following range of testing that we'll go through one by one. And I want to try to give you a sense of what we're thinking about with each of these tests in areas where there may be either economic limitations. It's important to understand that some of these may have more importance than others, but again, if you assume that people are normal, you might miss things that are important, whether it comes to infection or other things. So starting with the basic CBC, or the blood count, we're looking at their hemoglobin or hematocrit to assess, do they have a normal amount, or are they already anemic to start off? Addressing anemia early is important in terms of potentially giving iron replacement orally, or if you have access to intravenous iron replacement, that can correct that deficiency much more quickly. Potentially they could have B12 or folic acid deficiencies. We also look at in that test for the platelet count. There are pre-existing diseases to create thrombocytopenia. There is also pregnancy-related lowered platelet counts. So to have that baseline at the beginning is quite important. Next slide. Blood type and Rh factor and screening for antibodies that relate to blood type is quite important as well. Blood type, particularly when the Rh factor is negative, is significant, not necessarily for the pregnancy at hand, but for future pregnancies, because if the fetus were to be an Rh positive and the mother Rh negative, the potential is to develop antibodies against an Rh positive, which would be dramatically important in future pregnancies. And that initial antibody screen is to make sure that they haven't, if they're Rh negative, haven't already developed antibodies against the Rh factor. We also see sometimes antibodies to some of the major groups. Certainly most blood banks associated with hospitals like to understand if there's going to be anything that might delay preparation of blood for transfusion. And again, primarily though, to identify Rh negative patients and any risks to the existing fetus based on prior development of antibodies. Next slide. So a hemoglobin electrophoresis is looking at basically the types of hemoglobin that they have. We see sickle cell disease in our population, but we also find thalassemias quite often, and there are occasionally other variations. So some things like sickle cell disease trigger other testing, like urine cultures more frequently because of the increased incidence of bladder infections in sickle cell patients during pregnancy. And again, to learn whether there could be any issues for counseling parents about the fetus's potential to be a carrier for sickle cell disease or sickle hemoglobin C or other types of abnormal hemoglobins. So it's also partly to educate about their future child's risk. Next slide. In early pregnancy, we certainly want to look at a urinalysis and a urine culture. Symptoms of bladder infection during pregnancy can be masked a bit because of normal increased urgency and frequency of urination. So we do look at urine culture at the outset. A urinalysis can tip you off to other pre-existing medical problems by showing blood in the urine or excess protein. So a simple urinalysis and infection screen serves a significant purpose. Next slide. We do screen all of our patients at their first visit for drugs like narcotics, cocaine, marijuana, as well as other drugs. Unfortunately, again, in our inner city populations, these are common. The patients are again screened when they're admitted to labor and delivery, both for maternal risks as well as for potential for newborn effects of maternal drug use. We have social services involved at both within our institution, but also in the community to help patients, again, manage these difficulties if they've been identified. Next slide. Pap smear is a relatively simple thing. The follow-up, as in the non-pregnant state, would be potentially colposcopies and other things, but we take the opportunity to make sure that cervical cancer screening is up to date. If a patient has had documented normal pap smear within 3 years, it doesn't necessarily have to repeat it at the beginning of pregnancy, but making sure that cervical cancer screening is up to date is an opportunity. Next slide. So screening for infections covers a wide range of things. Cervically, gonorrhea, chlamydia, and trichomonas are very common in our community and are risk factors for premature labor. So these are important to screen for. We also screen for many serum infections, including hepatitis B, HIV, and syphilis. These are very impactful in terms of maternal health and can also affect, such as syphilis with congenital birth defects. Hepatitis C is something that is not currently routinely being screened. However, in our country, the American College of OB/GYN is currently looking at the U.S. Task Force recommendation is to screen everybody at least once in their lifetime. In this case, pregnancy would be an opportunity to do that. Much like genetic disorders, hepatitis C is something that you miss a lot of patients if you go just by who they are, what they look like, and so forth. So I think we will come shortly in this country to a point where hepatitis C will be part of our routine screening panel. Next slide. Rubella and varicella screening are partly important for future pregnancies. If either of these is found to be in a non-immune state, we're mostly counseling patients to try to help them avoid exposure to these infections while they're pregnant, because rubella can cause some defects in the fetus. It's also to help us identify patients that we're able to vaccinate in the postpartum period to protect them from, for future in future pregnancies and from disease in general. Most of the children in this country get the measles, mumps, rubella vaccine early, but we do see a fair number of patients who don't develop sufficient immunity or have lost some of their immunity. So that screening is an important part of their prenatal assessment. Next slide. And then we touched on genetic carrier screening that we recommend preconceptually, but we still offer it during the pregnancy, again, for educational purposes and risk assessment. The same test that's offered preconceptually can be offered in pregnancy as well. This is different, and we'll make a distinction in later slides from testing for chromosomal abnormalities that relate to the fetus in the existing pregnancy. So here we're still talking about screening for maternal DNA mutations that with the partner that carries the same could create a fetus with a disease. Next slide. So in our initial lab testing, there are certain pre-existing medical problems that trigger some additional initial tests. Prior pregnancies where someone experienced gestational diabetes, these patients should be screened with a glucose tolerance test early, and that would mean whenever the first visit is. Typically, this test comes up closer to 28 weeks of pregnancy, and we'll come to that later. But again, someone who's had pre-existing pregnancy-induced diabetes should be screened. People who are diabetic beforehand, we've already identified the problem. Diabetes pre-existing the pregnancy should require additional assessments if they've not been done prior to the pregnancy, including ophthalmology evaluation for retinopathy, looking at their hemoglobin A1C to see what their control has been like in the 90 days prior to the testing, because that does raise our suspicion for fetal birth defects and can lead to focused ultrasound of the fetus in areas like the heart later in the pregnancy. Diabetics do experience a higher incidence of thyroid abnormalities. That's particularly type 1 diabetics, I should clarify. So screening for thyroid disease, if it has not been done by their initial primary care, should be screened. And then looking at protein in the urine, EKGs, and metabolic profiles to look at things like BUN and creatinine, kidney functions, liver functions are useful as well. In patients who have hypertension prior to pregnancy, 24-hour urine is fairly useful because we get some assessment as to their renal function. It's also important that these types of diseases can increase the risk for preeclampsia in the pregnancy you're caring for. So as we develop symptoms, or patients develop symptoms later in the pregnancy, and you're trying to evaluate them for preeclampsia, it's important to know if they already had an elevation in protein as opposed to just finding for the first time at a later stage and wondering, wow, is that new or has that been already elevated? The complete metabolic profile, again, is looking at renal function and EKGs to determine that the cardiac rhythms and rates are normal. Next slide. So there are some managements that are offered with pre-existing pregnancy problems. In patients who've experienced premature labors, there is a current therapy called hydroxyprogesterone caproate, used to be called Delalutin and was used when I was a young practitioner, then fell out of favor and has been back as a regular offering for patients with this history to try to reduce the risk for premature labor. These are generally initiated as intramuscular shots starting at 36 weeks and occurring weekly until 36 weeks. There are many risk factors for people to develop preeclampsia in the pregnancy that you're managing. And as we're going to spend a couple of slides on, the use for 81 milligram baby aspirin as we call it, starting at after 12 weeks of pregnancy, is now a mainstay of our recommendation to help reduce the chance for preeclampsia in the pregnancy that we are caring for. Ideally, this should start before 16 weeks, but you can start as late as 28 weeks and then continuing onwards. Because this really has turned out to be an ever-growing list of things, I want to spend a few slides on the baby aspirin issue, so we can go to the next slide now. So this comes from the U.S. Preventative Task Force Services several years back. I think this is from 2014. And what they recommended is if a patient had one high risk factor or two moderate risk factors from the right, they would be candidates to begin this. And so the high risk factors, you look at previous preeclampsia and whether there was a bad outcome or not, but previous preeclampsia, twin or other multi-fetal gestations, chronic hypertension, diabetes pre-existing the pregnancy, renal disease, and autoimmune diseases. Moderate risk factors, multiple pregnancies, first pregnancies rather, obesity, family histories of preeclampsia, certain demographic groups, mothers with advanced maternal age, and then personal history of factors like low birth weight infants, previous other adverse pregnancy outcomes, and a long stretch, more than a decade since their prior pregnancy. So this list kind of has been fluid, and it seems like it's been expanding. If we look at the next slide. The uses of the baby aspirin have been anywhere from 81 milligrams to double that dose. There is a current active clinical trial, the ASAPP trial, which is being run through Cornell University in New York, and they're looking at low doses of aspirin in the prevention of preeclampsia, as we discussed. They just began or open enrollment for this study just back in October, and they don't expect to complete this till 2024, but I think we're going to get very robust data to determine the appropriate dose for the risk patients. And in our community, I think for the patients that seem to have more risk factors, that's where the higher dosing is being applied. So we can go on to the next slide. All right, so back to our prenatal care. When we look at our technological offerings to try to assess for chromosomal risk, aneuploidies, we're mostly really talking about Down syndrome or trisomy 21 as one of the primary ones. The data usually also carries over to trisomy 18, and we can break it down by, again, the time frame that different tests can be offered during the pregnancy. So one of the most common ones, which is, and when I say screening, we're talking about things that are simply identifying increased risk or no increased risk. They're not definitive tests, and a positive here would lead to opportunities for diagnostic testing. So anyway, most of our patients are offered the sonogram-based nuchal translucency. First trimester screening, it's done between about 11.5 and 13.5 weeks. There is a companion blood test that improves the accuracy of the screening, and many of our patients do show an interest in this, and it's covered by most of our commercial insurances here. Another test that is increasingly offered and accepted by patients is called cell-free DNA, or NIPT, non-invasive prenatal testing. It's basically looking at fetal cells that make it into the maternal circulation. It can be done between 10 and 21 weeks gestation, and often if patients have done the nuchal translucency sonogram and appear to have increased risks, they'll go on to have blood drawn for the NIPT to determine a little bit more accurately whether they are truly at increased risk before going on to invasive testing. Patients who choose not to do the first two are offered what's called the multiple marker test, or the quad screen. Quad because it's looking at the four items to the right: alpha fetoprotein, human chorionic, HCG, gonadotropin, estriol, and inhibin A. This is ideally done between 15 and 18 weeks, but can be done as late as 22 weeks. So again, if the first two are not done, this is a separate measure. Some of you might remember the old alpha fetoprotein test as a distinct test to look for neural tube defect risk, but with the availability of high-resolution ultrasound in experienced hands, the AFP alone isn't done for that screening purpose because the ultrasound is able to pick up the defects with at least as good a accuracy. Next slide. So patients who have abnormal screening tests or patients who are at increased risk by being over the age of 35 can choose diagnostic options. These tend to be more invasive and have a risk for disrupting the pregnancy, but they do give actual chromosomal information. So chorionic villus sampling is basically getting a piece of the placenta. It's done in the very early stages of pregnancy and carries a greater risk, about a 1 in 200 risk of disruption of the pregnancy. It's important to know if you're sending your patients for this type of screening that they should have a sense of what the risk of disruption is in the hands of the service performing it, because it can be as high as 1 in 100 and less so with greater experience and in determining whether to go for these transabdominally or transcervically. Amniocentesis certainly is offered to these patients as well, typically done between 15 and 20 weeks gestation. We quote an average of about 1 in 300 risk of disrupting a pregnancy, and it's a sampling of the amniotic fluid again for chromosomal evaluation. Next slide. So looking at the general structure of our prenatal care in this country, from the first visit to 28 weeks gestation, we see patients every 4 weeks. We're doing and offering testing as we've discussed partly up to now. We're reviewing results. Their visits involve blood pressure checks, checking for the presence of the fetal heart rate, and after 20 weeks, when we pass the level of the belly button, we're using centimeter measures of the fundal height as a rough assessment of whether there's adequate growth. We'll come back to different testing during this time period beyond the screening we've talked about so far. Between 28 and 37 weeks, we see patients every 2 weeks. We're again looking at tests, reviewing things, checking blood pressures, fetal heart rates, and fundal heights. The Tdap vaccine is recommended in pregnancies to provide the newborns with some protection against the P in Tdap, which is pertussis, also known as whooping cough. Certainly babies get their routine vaccinations at 2 months and 4 months and 6 months, etc. But there is a window where they're at risk that if exposed to pertussis, they can get fairly sick. And so they do develop a passive immunity when pregnant women are given the Tdap vaccine, ideally after 27 weeks. At around 20 weeks, RhoGAM is given if patients are Rh negative. And during that time frame of 28 to 37 weeks, there may be additional APT or antepartum testing, such as monitoring the baby's heart rate patterns or sonographic assessments. And these would be done based on medical problems that have been identified where babies can be at risk. Sonograms, likewise, can be following growth during these time frames or following up on abnormalities, which we'll touch on shortly. In the last 3 to 4 weeks of pregnancy, we're screening for Group B beta strep, a common bacteria to the pelvic area, which in the non-pregnant patient really doesn't have any significance at all, but in pregnancy and during a vaginal delivery, babies exposed to this without knowing can lead to sudden and sometimes even death to fetuses. So the screening is routine, typically at 36 weeks, and then that is treated with antibiotics in labor to protect the babies from infection. We go over labor warnings through this time frame, and again, much closer eye on changes like blood pressure and checking fetal heart rate and monitoring the fetuses, mostly if they go to what we refer to as late term, which is beyond 40 weeks. We like nature to do its own thing and have spontaneous labor occur. However, babies get bigger and sometimes placentas stop functioning, so we do monitor babies more closely after the due date. Next slide. So as we look at prenatal visits going from the first semester to the second trimester, after the 10 to 12 week range, we should be able to hear a fetal heartbeat by a small hand Doppler. I don't think anyone's using the fetoscopes anymore, but these are devices that kind of clip onto the listener's head, and by putting direct pressure on the abdomen, it transmits sound that way. But I think hand Dopplers have been fairly accessible. Between 15 and 20 weeks, we talked about the quad screen if no first trimester nuchal translucency sono was done. And then typically around 18 to 20 weeks, we do recommend and have the technology to offer anatomical surveys for patients of the full age range. Here we're basically looking at the details of all the major organ systems, and if we're identifying any problems with the fetus or the placenta, that can lead to certainly follow-ups that will depend on what the abnormality is. Next slide. So again, ultrasound is routine, 18 to 20 weeks. In qualified centers, it has replaced AFP, as I mentioned, for neural tube defect screening. Next slide. So some of the things we can see that that will lead to follow-up ultrasound could be changes in the cord insertion, either marginally inserted because of associations to decreased fetal growth. You can see cords also being very shakily attached, for lack of a better word, called a velamentous cord insertion, and sometimes those will be associated with blood vessels crossing over the cervix, similar to the risks of placentas which cover the cervix, known as a placenta previa or a low-lying placenta. Typically, those types of changes will be followed up between 28 and 32 weeks, where we hope that the placenta will migrate up and away from the cervix. That would obviously determine the route for delivery, because with placental material covering the cervix, vaginal delivery is impossible. These patients also sometimes are identified due to bleeding during pregnancy, and these can be very critical problems requiring emergency delivery, sometimes at premature ages. The sonograms often can be done to follow specific fetal growth in patients with diseases like hypertension, diabetes. In multiple gestations, we're comparing individual fetal growth to each other to make sure that there is no wide discrepancy in growth. Growth can be done to follow growth restrictions or larger babies, and then sometimes we're following things like maternal adnexal masses or fibroids, and these are just to name a few. Next slide. As we move from the second trimester into the third trimester, between 20 and 24 weeks, we give them an order slip to later perform what we refer to as 28-week labs, and the best time is probably around 26 weeks or so. We're looking at primarily the glucose tolerance test, the GTT at that point, because by 28 weeks, the placenta itself creates something called human placental lactogen that basically, I discuss with patients, as fighting their own insulin. And so if there's any tendency to become a diabetic at this point in pregnancy, that can be revealed. And so that's very important screening. I mentioned that after 20 weeks and the uterus passing the belly button height, we're using centimeters to measure the fundal height from the pubic bone to the top of the uterus, and there should be a match between the number of weeks of pregnancy and the number of centimeters within about a 2 to 3 centimeter measurement. So if you're out in an area with low resources, a simple measurement like that could help you select patients who clearly might show a lag in fundal growth or excessive fundal growth, and at least help to counsel your patients and potentially have them referred for actual fetal ultrasound growth estimation. Mothers tend to notice fetal movements as early as 15 weeks, but it can be as late as 24 to 25 weeks. I mentioned earlier that at beyond 27 weeks, we like to administer the Tdap vaccine to give the fetus passive immunity against pertussis. At 28 weeks, if a mother is Rh negative, they get a RhoGAM shot preventatively, and this circulates for about 12 weeks in the system, so allowing any fetal cells that might trigger an immune system response and development of anti-Rh antibodies to be pulled out of the system, so reducing risk for future pregnancies. It's worth mentioning that for mothers that are Rh negative, RhoGAM shots sometimes are given in earlier pregnancy, even with early miscarriages. It's a little controversial when it becomes significant, but in bleeding in early pregnancy in Rh negative mothers warrants RhoGAM shots at that time, as well as at 28 weeks. I'll mention briefly that since COVID-19, we have altered our prenatal visit schedule a bit. They still have their initial visit, of course, to confirm pregnancy, but then often they're going to our referring center for something like the nuchal translucency, where their blood pressure is also usually checked. They're going for their ultrasound anatomy scan at 20 weeks, where again, their vital signs are being checked. Sometimes patients have chosen to have live visits once the the fetal heartbeat can be heard and to show growth, but they also have taken advantage of telephonic or video remote visits just to touch base on symptoms and to educate them as to changes between their first and second trimester. Typically after 24 weeks, we've recommended live visits, not only for the testing and education purposes, but to start really keeping a closer eye on blood pressure ourselves and monitoring fundal height growths. Next slide. For testing and treatment, I mentioned these 28-week labs. So the glucose tolerance test I referred to before, probably the most important piece, but we also do repeat their blood counts to reassess for developing anemia, rechecking their type-in screen, and rechecking for syphilis and HIV. If patients do have an elevation in their 1-hour glucose tolerance, whether it's an early one or at the normal times, then they have to come back fasting for a longer version. This is a whole side discussion, but where you set your cutoffs is sort of determined by how many patients truly affected by the disease you want. This is true for any test with regard to its sensitivity and specificity. We in our practice have set a lower, the lower range of known cutoffs is 130 versus say 140 or so in some other centers. Obviously, as you set your 1-hour screening lower, you're going to have more abnormalities and more patients have to go on to 3-hour. However, it gives you the opportunity to truly identify more patients who are truly affected with diabetes. Similarly, for the 3-hour test, the common abnormality would have 2 of 4 results be abnormal to be diagnosed. Again, if you choose, as we have, to use 1 out of 4 as abnormal, we start educating and following finger sticks more closely. And in patients that we've not too long ago taken this approach, we are finding that we are following diabetic patients. So again, you do put more people through testing, but you do identify true disease more frequently. Next slide. So in terms of testing the fetus, which in most situations starts at about 32 weeks, for most situations, there are many indications, including pregnancy or pre-pregnancy diabetes, hypertensive disorders, identification of fetal growth restriction, multiple pregnancies, amniotic fluid abnormalities, whether low or excessive, pregnancies that go beyond the due date, late-term pregnancies, and if someone had a prior stillbirth or complains of decreased fetal movement. The testing often is just putting the baby on the fetal heart monitor and looking for a nice pattern of accelerations within about 20 minutes. We can also do sonographic-based tests known as biophysical profiles, which look at things like baby's breathing motions, gross body movements, flexions and extensions, amniotic fluid, and the fetal monitoring strip. Next slide. So lastly, as we come to the end, is timing of delivery. For most patients, we're very happy to have them go into labor spontaneously, but by 41 weeks, if they have not, due to potential larger babies and increased chances for fetal demise, we recommend induction of labor. Otherwise, electively, once patients reach 39 weeks by, quote, good dates, they can choose to electively be induced. Our maternal fetal medicine specialists often say that nothing good happens after 39 weeks. So we do have patients who choose that for any number of reasons. Certainly for certain medical problems, medical indication for delivery may require it prematurely, things like preeclampsia, for example, other situations that can occur. And I mentioned that after 41 weeks, we recommend induction. So next slide is just a thank you for your time late in the day. And it's also at the end of a long work day for me. So thank you for your attention. And I think we have a few minutes if there are any questions that anyone has.
Thank you, Dr. Taro. We have a lot of questions.
Okay.
Well, our team is selecting them. I want to thank you, give a special recognition to our organization team, members of LAUGHH Foundation and Acome, that work together every year to provide medical care and education to people living in small towns with low incomes in Santander, Colombia. This year, overcoming the SARS-CoV pandemic, they have decided to keep on going with education and training to medical students and physicians around the world. Thank you so much, guys.
Oh, it was a pleasure. So I see that Cynthia Lopez has a question. She asked, does a woman with O negative blood type, or any major letter but a negative blood type, RH factor, and a partner with an RH positive blood type, must they always get RhoGAM in every pregnancy? Her second question is, what are the consequences of not getting a shot other than for miscarriage? So it is important in each pregnancy. We don't know a fetus's blood type until they're born. So the potential in a couple that has an Rh positive husband and Rh negative wife is that the baby could be Rh positive. So the potential for fetal circulating cells to enter the maternal bloodstream we know exists. We take advantage of that with our cell-free DNA screening. So if it is unidentified, the mother will develop an immune response, much like to an immunization shot, and develop anti-Rh antibodies. So if she then is pregnant in the future and has these antibodies, which are permanent, her immune system will attack a fetus in her body that has Rh positive in a future pregnancy. And autoimmune hydrops is a very significant complication of pregnancy that leads to increased morbidity and mortality. So it is important because in each pregnancy, that fetus carries that risk of being Rh positive. So the second question in terms of consequences of not getting a shot is to develop these antibodies. Even with miscarriage early on, there are enough fetal cells to create this immune response. There are what we call mini doses of RhoGAM, which is simply a lower dose, or you can actually have a blood bank calculate the amount of fetal cells in the maternal circulation. There's a test called a Kleihauer-Betke test. And so let's say you have a patient who's 15 weeks pregnant or in pregnancy, and she's in a car accident and there's some abdominal trauma. That also is a concerning time that a placenta blood could cross from the fetal to maternal circulation. So in those situations, sometimes we'll use a Kleihauer-Betke to determine or quantitate how much fetal blood has entered the maternal system. And we've had occasionally patients who require even greater doses. We had a situation, rather interesting and case reportable situation where somebody who was thought to be Rh positive received a nonspecific blood transfusion, came in hemorrhaging. The blood bank later reported that the patient actually was a weak Rh negative, and I'm confusing the blood bank pathophysiology, but so she potentially was exposed to whole units of blood, which is a high number of orders, and she ended up getting a calculated extremely high dose of RhoGAM to try to equate to the amount of blood. So sorry, that's a long-winded answer. Yes, it's important to do in each pregnancy for an Rh negative mother, both at 28 weeks. Once she's delivered, that baby's blood type can be assessed, and if it's Rh positive, she gets another RhoGAM shot postpartum. If the baby is Rh negative, then she does not need a postpartum RhoGAM shot.
Thank you, Dr. The next question is, regarding preconceptional care is really hard to get to women before they get pregnant because our culture is not prevention and planning. How can we about that?
That is challenging. And that's true in our country. Probably, unfortunately, as often people are reasonably good about coming to their gynecologist apparently, but not very good about going to a primary care physician unless they're sick. And when I say sick, I'm usually talking a cough or cold as opposed to diabetes or high blood pressure. I think really, unless there's an opportunity for that, unless it's really about education. So I think if you look at given communities, particularly if you see high incidences of high-risk pregnancies that are only identified in pregnancy, I think community education is an area of focus. So something for a medical student group to focus on is community education about the importance of good health for people attempting planning pregnancy in the future.
Next question, it is okay to administer folic acid before even pregnancy is in the picture?
Yeah, so folic acid, folate, I mentioned is quite important. We recommend that patients start with no other histories. Folic acid or folate equal to 400 micrograms, that's 0.4 milligrams, ideally for a month prior to conception occurring. And that's the time frame that we understand helps to reduce the chance of having a neural tube defect in a pregnancy that occurs subsequently. So yes, important to recommend that not a whole prenatal vitamin, not a multivitamin, but just folic acid on its own.
Thank you. Can a woman of age 30 plus have a higher chance of pregnancy and delivery of a healthy baby if she takes great care of herself and takes all supplementation needed, even if it's her first pregnancy?
Absolutely. And I can't speak to statistics around the world, but in the United States, I think that the ability for women to follow their careers and follow other interests in life have led to a large population of patients, not only 30 and older, but 35 and older and 40 and older. And I can tell you the number of patients in our practice, in my solo practice before I joined my current group, had, I would say, at least half my patients 30 and older. And so extremely common. And absolutely, again, identifying, I think going for women really of any age, but certainly as women get older, seeing their primary cares to make sure they're healthy to start with, this whole idea of really optimizing your health prior to getting pregnant, and understanding what things you can do to make your pregnancy healthier is very important before pregnancy occurs. But there's no question we have healthy, beautiful families with mothers 30 and older regularly.
In late initiation of prenatal care control, what can we do to maximize our time and be prepared for anything? Just had a patient that realized she was pregnant 13 weeks in pregnancy.
Yeah, so I'm in a very busy inner city area, and we have, in spite of many hospitals, many medical centers, we routinely get patients walking in the door with no prenatal care. And many of them are coming because they're having some kind of significant problem, bleeding abnormalities, hypertensive issues. It's not limited to any part of the world. So the best we can do when we have access to a patient that is identified a pregnancy, even late in pregnancy, looking at basic things, blood pressure. I think glucose evaluation, even if it's just a random finger stick, is very helpful. Trying to assess how far along they are by simple measures. These are basic things you can do with very limited resources. If you have the ability to do those basic things, certainly if you have access to laboratory testing, screening for diabetes, quite important because it's a fairly common change that can occur in pregnancies. And some of the other initial labs we talked about, certainly for infection screening, have validity as well. So I think we try to do everything once we get a hold of somebody and catch up on all the things that were missed. It's not uncommon for us with access to technology that also with limited prenatal care or late prenatal care, we're also usually doing growth follow-up sonograms on a monthly basis. We do fetal testing because they're just more unknowns from the past. So we do everything we can once we've identified a pregnancy.
Who is in charge of medical prenatal care in USA? Obstetricians, or it can be done by primary providers?
So I would say the vast majority of care, even in rural areas, is done by obstetricians. In this country, the family medicine, which is a little bit different than regular internal medicine, in that family medicine sees everything from children to adults, male and female, as well as pregnancies. And even here in Baltimore, one of my colleagues who was a family practice resident when I was an OB resident always had an interest, and he went on actually to also do critical care training. And so at one point in his middle of his career, he was doing intensive care attending work. He was delivering about 10 to 15 babies a month, which is reasonably busy. And he was doing primary care for children, women, and men. So that's a bit crazy, but certainly the training and ability to do obstetrics is certified and legal for family physicians, not so much for internal medicine, which is your basic medical people. We do also have, fortunately, a large group of midwives in this country. I have practiced in a few different setups where I worked in we call it a collaborative care, where they're usually doing, so midwives are certified to do low-risk obstetrics. They hopefully identify if problems occur that they're using obstetricians or high-risk OB consultants to help identify risk, manage risk, and identify when these patients should move out of low-risk care to high-risk care. So it's OBs, family physicians, midwives, and that's what we have going on in this country.
Thank you, Dr. Adachi. I'll have a couple of questions because we do things a bit different here in Colombia.
Yeah.
And I wanted just to mention some things about just to know what you think about it, right?
Mm-hmm.
Okay, so the first thing is that we as people in charge of prenatal care, we used to test on a first visit for cytomegalovirus, toxoplasmosis, and rubella with IgG and IgM. What is that indication in USA?
Yes, well, more of that testing comes up when a patient identifies that they've had a potential exposure to either CMV or parvovirus. So some of that is really determined by history. It's not routine screening. However, if certain complications in pregnancy come up, if you think, for example, like excess fluid can be related to infections. We think of we call it the torch titers, and that covers toxoplasmosis and the range you were talking about. So it's not part of the routine screening, but it is based on their medical history, exposures that they're aware of through, my child came home and I was told that someone has parvovirus. I have a cat, I changed the kitty litter, so we think of toxoplasmosis if they're handling the feces. So it's mostly driven by their history or some sort of a finding that raises the suspicion for one of those infections. Is it done in Colombia because of a higher rate of those infections?
We used to do it like a routine, but I have seen like 2 patients in all my practice with toxoplasmosis. So that's the other question is that besides that, we also screen for women with for group B strep around their delivery. So
Yes.
did you do the same?
Yeah, I maybe went through that one too fast. So that is routine for us. We typically, until really just a few months ago, the standard of care here was to do it at 35 weeks of pregnancy. The test has validity for a limited time, and so just recently, the national recommendation here was to do it at 36 weeks instead, because since the test is valid for 5 weeks, if patients were going to 41 weeks, the test wasn't valid anymore. So we had a false result that could change. So by now starting that screening at 36 weeks, it covers them all the way till 41 weeks. But it is a routine test. We screen all of the patients for that. And typically our result takes several days to come back. So if someone shows up in labor and delivery, we have a rapid version that we can get very quickly for patients who are not identified yet.
Okay, thank you. The other question was that we learned at medical school that like a woman with a previous C-section can try at the vaginal delivery, but we don't do that much here in Colombia. If you have a patient with a previous C-section, we usually see them in a C-section again. So what do you guys do? Did you try for a vaginal delivery or not?
That's a wonderful question, and I'll try to make the answer short. Yes is the short answer. We strongly recommend, provided one thing, that the prior cesarean section was done through what's known as a low transverse incision on the uterus itself. Incisions that are made vertically or extensions have an increased risk of uterine rupture. So we're talking about patients with a prior low transverse section, the most common type. We do encourage that because in most cases the success rates are reasonable, and there is we have through our Society of Maternal Fetal Medicine here a sort of a question-oriented calculator, so we can approximate their success based on questions of how far they got dilated and other factors. But the main reason that we encourage the trial of labor after cesarean section is that increased numbers of cesarean sections are associated with maternal increased morbidity and mortality. If you look at also the locations of placentas, like a placenta previa, with each subsequent cesarean section, the chance of developing placental invasion into the uterine muscle, placenta accreta, percreta, different names for that, is higher and higher, and those could be catastrophic at repeat cesarean. If there's a placental implantation into the uterus, it increases the chance of hysterectomy required at the time of cesarean. At the time of cesarean section, and that as a catastrophic surgery also is usually associated with really excess blood loss, increased incidence of DIC, and so it's all about keeping the repeat C-sections as low as possible. Having said that, we do see a lot of patients that come to Baltimore in our hospital, in particular, who come from other countries, African countries and Latin American countries, who have already had 2 and 3 C-sections. And I can tell you that it is a struggle to be doing a 4th or 5th C-section, even without complications, just because of scar tissue. There is a greater chance for anatomical disruption and distortions. Yet another reason. So there is a push, and has been a push for many years, and at every hospital, to try to keep the cesarean section rate lower for that reason. So
Thank you, Doctor.
my pleasure.
My last question was about TSH. We also do it like a routine here, but also I don't know if you could just name a few tips about the management of subclinical hypothyroidism and real hypothyroidism in pregnancy girls.
Right. Well, as I mentioned at some point earlier, in type 1 diabetics, it's recommended simply because there's a higher association of thyroid abnormalities. We do take care of a lot of patients who come already on thyroid medications, and so we're obviously trying to just keep track of their thyroid functions per trimester and adjusting doses as necessary. In terms of those patients with sort of subclinical thyroid dysfunction, we really use co-management with usually their endocrinologist if they're being seen or their primary care doctor, ideally trying to at least make sure that, so in pregnancy, some of these thyroid tests are altered by pregnancy state. So in pregnancy, we limit the testing to the thyroid screening hormone, TSH, and the free T4. Those usually are unchanged in pregnancy. And so if there's a question of subclinical thyroid dysfunction, we're simply just following those measures through the pregnancy and not necessarily changing or doing treatments if they're staying in normal ranges for that.
Thank you so much, Dr. Adachi. I think we have a last question. Yeah.
Sure.
Are there any side effect or risk associated with folinic acid supplements for women that aren't trying to get pregnant?
Not that I'm aware of. So there really isn't a downside to getting some. In fact, I'm not a nutritionist, but I think folic acid, just for general human female care, has a place, and it's in most regular multivitamins in this country. You'll find actually 800 micrograms in just an over-the-counter multivitamin. So folic acid has a role, and again, you as medical students and any primary care docs out there probably know a lot more about the role of folic acid in the non-pregnant patient than I do. But there's no significant downside to getting 400 or 800 micrograms as a daily supplement. And if there's any chance of pregnancy occurring, even unplanned, then by all means, knowing that you have that dose in your system has a value to reduce a potentially avoidable neural tube defect.
Well, Dr. Taro, I think that's all. Thank you so much for being here. It was such an amazing conference, and I hope to have you in our next mission.
Thank you. It's nice to see your face again too. Thank you all very much for attending. Good luck with the rest of the conference. Ciao.
Ciao. Well, that concludes our 4th day of conferences. Thank you so much for your participation and patience. Remember to fill the attendance form that will be open 1 hour from now, and see you next week.